probably up to 200,000, it might even be more patients per year. And I put this in context with the glioma population, which is probably filling all the other chat rooms, which is about 20,000 a year. 5 to 10% of patients will present with brain metastases as their first sign of cancer, and some specific cancers are really common getting into the brain, non-small cell and breast cancer in particular. Here we go. So the 5 most common are listed here, but basically it just means that they're moving upwards and coming into the brain. There are 2 that I listed that are just really uncommon, prostate and liver cancer. So I never assume that it's prostate or liver cancer that has gotten to the brain. If the patient has that, they might actually have a second primary disease. Diagnosing a brain metastasis is very similar to diagnosing a primary tumor. Patients can have headaches, high pressure symptoms, seizures, weakness, or they could have none of the above if we think they're high risk for having brain metastases and we're simply screening their brain often. And here's how we get the picture. We often use CT scans in an emergency room or an MRI. It's really critical to use contrast agent, either gadolinium or the iodine base for the CT scan, because it really shows up much better, as you can see in this picture. It just gives us more information, although it's not perfect. And these are our basic treatment tools and categories. So one is surgical, one is radiation therapy, and the other is using chemotherapy or now targeted oral therapies. So how do we treat brain metastases? Well, typically we've done surgery for 1 to 3 brain metastases, and the prior standard of care used to be to follow with whole brain radiation. Targeted radiation really started to come into play probably about 15 years ago. And we're starting to do radiosurgery, or SRS, targeted radiation, for disease that is less than 2 centimeters. And actually we now do it for bigger mets too, but the control rate's actually really good for specific types of cancer. So lung and breast cancer, actually 97 to 99% of those tumors, once zapped, will not grow again. It's a really nice control rate. But when patients had more brain metastases, we would sometimes opt for whole brain radiation, and rarely did we really talk about chemotherapy. So that was like back when I was in medical school, but things are changing a lot. Why? Because a lot of patients have way more than 3 brain mets. Patients and MDs alike do not like whole brain radiation. Why is that? Because on the left-hand side of the screen, you'll see that when we radiate brain, it changes what it looks like. And it actually changes function too. So 4 to 6 months out, up to a third of patients will actually start to have changes from big radiation fields. That white smudgy stuff is not supposed to be there. And I kind of describe it as it just slows everything down. If the signal has to go through that white scar tissue stuff, it just isn't as fast. And so patients feel that. They feel their cognition get worse. They sometimes get walking problems, and even bladder and bowel can get affected as well. So we try to avoid this if we can, right? But our radiation oncologist at Stanford likes to say, our brain specific guy says, there's nothing worse for your brain than progressing tumor, which is also true. So as things have sort of evolved, there's now more and more data supporting the small targeted radiation for a large number of targets. And we're starting to get more creative about how we use systemic therapies. So things that you take as a pill or as an IV. So when do we cut? When do we actually do surgery? Because in my view, I feel like we don't do it very often. And that's true, because we really are doing it when we need to prove what that metastasis is. So like I said, prostate and liver cancer, I usually think what's happening in the brain is not those 2 things. So sometimes we have to go in and prove what it is. If the patient has really symptoms, a lot of them from swelling that are not getting better from steroids, or I think they're going to be on steroids for a super long time. Steroids are not good for you over the long term. Or concern that if we just radiate alone, that we're going to worsen your symptoms in the short term, and then we'll still have to go to surgery, but it'll be emergency. So those are the reasons that we cut. If we're not cutting and we go radiation, these are the kind of broad overview of options. Whole brain radiation, you can see that the whole field there is covered with high dose red radiation. Then we have a newer technique called hippocampal sparing, which is really, we think, the deep memory centers, how we encode memory, and try and spare them from the highest doses. This is appropriate for certain patients, but not everyone. If you've got disease there, can't spare it, right? And then stereotactic radiosurgery, SRS, gamma knife, cyberknife, those are brand names of the same thing, super targeted radiation. If we cut, we know we should follow with radiation. So post-operative radiosurgery is a standard of care. It booted out whole brain, thankfully, because whole brain improved overall control of disease in the brain, but didn't really improve how long patients lived. And it is associated with a lot more cognitive decline. So I don't know if you're familiar with these plots, but basically the ones that are, it's time on this way axis and sort of how good you're doing on this way axis. And so you can see over time, if you use whole brain radiation, those patients have cognition drop much faster than if we're using stereotactic radiosurgery. And we like to do that within 1 month of surgery if we can. So if you have 1 to 4 METs, do you have to have whole brain, right? Remember I said if you got more than 3, we can offer whole brain. The answer here, which is from 2016, is really, we don't think so anymore. The overall survival looks about the same when we use SRS versus whole brain radiation, and cognition seems to be a little bit more intact over time. And how about if you have more than 4? This data is from Japan from 2014, showing that up to 10 brain metastases, not really much of a difference. If you use, 1 as your cutoff, 4 as your cutoff, or 10 as your cutoff. So this allows us to use targeted radiation in many, many more patients than we were doing before, as long as they have access to it. Now, can we delay radiation using systemic therapies? And the answer to that is, I think we're getting there, and I hope it's going to continue getting better. This has historically been cited as the reason we can't use therapy in the brain is because of the blood-brain barrier. Notice on the top, that's a healthy blood-brain barrier, and it actually is kind of like blocking out poison. That's its job, right? But a diseased blood-brain barrier in a brain metastasis or a brain tumor has holes in it. And why do we know it has holes in it? Well, we know it has holes in it because we can see them. And the way we see them is by giving you that little dye that's a small molecule that's getting in. That means it is broken. We also know that it's not probably all the blood-brain barrier because methotrexate is a small molecule. Doesn't always work because it's the wrong cancer, right? Bevacizumab is a big, huge antibody. Doesn't get in per se, but it still has effect because it's doing something important with the circulating proteins. And drug injections have generally not been that useful. So probably it's not all about just having the drug get in. And brain metastases do respond to systemic therapy. We've known this for a long time. This is a study I ran in one of my patients who got an experimental therapy that clearly, without radiation, cleared up this patient's brain metastases. So we do know it happens. Can we delay radiation, including stereotactic radiosurgery, using chemotherapy? The answer is probably. This is a small study, randomized between targeted radiation and chemotherapy, and you can see there's no difference. Those lines are totally overlapping. They still go downwards, unfortunately, but totally overlapping lines, no difference. So the study stopped because we couldn't accrue enough patients, and same here. This is a newer study, 2021, same idea, that basically no difference in those lines. So it means you could just use the chemotherapy you were going to get anyway and avoid radiation altogether. So there are so many possible ways to target cancer now. So we have all these possible ways to think about how do we get these guys into the brain. Monoclonal antibodies, enzyme inhibitors, signaling transcription pathway, just to give you an idea of how insane this is. This is an old slide. Since 2001, the first targeted therapy. This is just, I think there's maybe 25 or 30 targeted therapies on here, and there are way more than this. And this slide is probably only 3 years old. So tons and tons of things to think about. And so we're going to basically do a little bit of a whirlwind tour here to just show you where we are now. And this is completely different from when I was in med school, which hopefully doesn't look like it was that long ago. So EGFR inhibitors for patients with lung cancer. First report of central nervous system activity is in 2003, and reports thereafter showing almost 90% of patients were having some sort of response in the brain when given this just oral pill, right? So that led to a shift in practice where people just automatically started delaying people's radiation. Oh, we'll give them the pill first, take a new scan, and see what happens. And now fast forward to 2018, and we're actually looking at how this works in patients as opposed to just doing it as one-off. This is a clinical trial, big one, thousands of patients with lung cancer, showing that the third generation of drug pill that targets EGFR actually decreases the number of brain metastases that you develop, but also leads to better overall survival for patients with brain metastases. This is another way of looking at that similar kind of data. Again, this is osimertinib, the third generation. On the sort of the far left is start time 0, and you can see that patients are getting sort of ongoing treatment with overall survivals up in the multiple teens of months, almost 20 months. And when you think about what it was when I was in med school, it was less than 6 months. This is a big, big leap. And you can see progression-free survival from the central nervous system is all the way out at 25 months. That means we're getting there. We're getting to control the brain with drug. This is a waterfall plot. So the other one is called a swimmer. You're just swimming sideways. This is a waterfall plot because in a perfect world, all of those lines are going down, which means everything is shrinking. Okay, bars going up means it grew, bars going down means it shrinks. I'm going to show you a bunch of these, but this is an ALK inhibitor, so different class of patients, but still almost all of those bars are going down. This is for patients with BRAF and melanoma, bars almost all going down. So non-small cell actually has some of these, and brain cancers, primary brain tumors have this too, so we're using this in brain now too. For patients with melanoma who don't have a target, we've actually got one of the few really nicely done trials of untreated brain metastases. So those are all patients who may or may not have had radiation in the prior slides. These patients did not have radiation, and you can see that the intracranial and body progression-free survival are about 60 to 70% in both. And that means if you look at the far end here too, this is progression-free, so not even overall survival. I'm talking about almost 2 years. And we are using the cure word for patients with melanoma in the brain. When I got to medical school, if you had melanoma in your brain, it was 3 months. So this is it actually is an incredible leap. This is almost nothing short of a miracle, in my opinion. And you can see without radiation from baseline scan to 1 year, can you find the MET? Pretty hard. There's a little dot there, but that's it. That's pretty amazing. And that's not the only place we're making difference, right? So these are NTRK-driven cancers. Sometimes 5% of our patients will have this or less, more common in pediatrics, but basically same idea. CNS response. And MET inhibitors, same thing, CNS response. So we have to test for these things. And RET inhibitors, CNS response. Remember, waterfall plot going down means all those things are shrinking. This is another, just a picture of the RET inhibitor working. You can see from left to right on both screens that brain metastases is disappearing without radiation. For patients with HER2 positive breast cancer, again, remembering that the lines going down mean like you're having progression at that time point. You can see that the patients who were on tucatinib on this study, that's the blue line, did much better than the patients who were not getting tucatinib. And this is with active brain metastases. Again, patients who are not having treatment with radiation. Waterfall plot for patients getting TDM1, again, HER2 targeted. You can see that the waterfall plot largely falling. So another option for our HER2 positive patients. There's more updated data on this drug that I need to put in here, but trastuzumab deruxtecan definitely having meaningful CNS response, not only in breast cancer, but HER2 positive lung cancer, probably HER2 positive GI cancers. Really kind of awesome tool for us. And then for a really huge portion of patients, this is targeted at non-small cell, but KRAS is present in like 30% of all cancers, previously thought to be undruggable. However, there is data for, this is animals, you can tell those are not little humans, getting better when they're getting this KRAS inhibitor. And I'm going to show you again, waterfall plot, not radiated patients, drug alone, oral pill, most of those patients' brain mets shrinking. So now, okay, what do I do? Should I radiate my tumors or not? Well, a well-designed trial should be run, but we don't have one. So what does the timing of radiation matter? Our group says probably not. This is using a third generation drug. It doesn't look like those lines are all together, but if you zoom out, they are. Overall survival, pretty much the same. So don't have to necessarily radiate everyone. This is using a first generation drug, probably mattered more because the first generation drug wasn't as good. And this group says, yeah, probably you should get radiation first. What do I think? Well, I take into account penetration of drug into the brain, if we know that, treatment tolerability, you got to stay on the drug for it to work, number of mets you have, anatomic location, meaning where are they and what problem are they about to cause if they grow, access to the drug, access to coming in to see me a lot. So if you live in the middle of nowhere, maybe just doing drug alone is not your best choice. Maybe we do need to radiate 1 or 2 that are going to get you in trouble and then do drug for the rest. Access to urgent surgery, patient preference plays a big role, and trust that you're going to call me and tell me if something's wrong. Because if I don't have that trust with my patient, it's very hard to make a decision to not use radiation, right? So I'm going to switch gears a little bit here and jump into a special kind of metastases that I take care of and really like motivates a lot of what I do. This is when the brain metastases are actually in the coating of the brain. So imagine like powdered sugar coated on the top of the brain. That's really what it looks like on an MRI. It's really hard to see, but it causes a tremendous amount of disability and actually leads to death in most patients when it happens. It's a tough diagnosis because we can't see it very well. You can see that little squiggle maybe. That's maybe all you're going to get. So we actually do a lumbar puncture where we take the fluid out of the low back and look at it under the microscope. But even that is really not perfect. Maybe 70% of patients will pick it up the right on the first tap. So we're looking at alternate ways to find that. This is work from Stanford showing that cell-free DNA, just like you may have heard of it getting out of your blood, you can, this is showing that it correlates with tumor in blood, but we also, our group showed that it correlates in the spinal fluid. So this is one of my patients with melanoma who was super, super sick, started a BRAF inhibitor, and all the levels of CS cell-free DNA went down. And then as he got more symptoms came up. So we've shown that it actually is possible to track patients with lepto with that as well. So how do we treat it? Well, we can use palliative steroids. We can use radiation, but often it's whole brain. Sometimes we just do the skull base, just the bottom part, if that's the most active. We use intracompartmental therapy. What does that mean? Picture right here shows that this is a port that goes into the fluid space where we can give a specific number of drugs, not too many. But largely, I like to use the antibodies. So trastuzumab, I think, causes the least amount of trouble for our HER2 positive patients and actually can be effective in well-chosen patients. We can use systemic chemotherapy, and prognosis from this particular complication is really dependent on if I have a good targeted therapy and the general overall responsiveness of disease. So what do we do when we're using systemic therapy? We use these tyrosine kinase inhibitors. We talked about the pills. This is a patient with BRAF V600E melanoma, probably the most leptomeningeal disease that you'll ever see. It's very, very obvious. That's why I use this picture, but you also can see that it responds very nicely to this oral pill. Melanoma with leptomeningeal disease, prior to this targeted therapy, survival probably a few months. This is a 9-month duration of response in this patient, and this is just the first generation of drug. Okay, so this is the reason this got published was because it was so exciting that it happened, but we're now on like 2nd and 3rd generations of almost all targeted drugs. So longer durations of survival. This is osimertinib, 3rd generation EGFR inhibitor, 20 months-ish of survival, just pill alone, no radiation for a prior fatal complication of cancer. Again, nothing short of a miracle in my eyes. What else can we do? Well, this is what I was talking about, getting trastuzumab or Herceptin. You can give it right into the fluid. And you can see here that patients who did get that are actually, with breast cancer, the median survival here is about 12 months, a year, which again, when we think about weeks to 3 months longest, this is pushing it out quite a way. And we are using this more and more in my clinic too. But how do we know that the target is even there? So that's part of what I've been working on. Like I said, with the cell-free DNA, this is when you actually look at the cells and you stain it for the HER2. This company called Biocept is the first company to market. I work with them with some of my disclosures, but they're the only game in town right now until someone else does it better. And And you can see here that you get the fluid and you can actually look for the HER2 amplification just like you would in a breast cancer diagnosis, see if it's there, and then make the decision with the patient to do the intrathecal therapy or not. So same considerations really when treating leptomeningeal disease. How does it penetrate? Is it tolerable? Extent of disease? Can you come see me? Are you going to be able to get an Ommaya placed? And is that going to be okay with you? Patient preference, and trust that you're going to call with new problem if we take a conservative approach, right? And why do I think it's so important? This is a patient of mine, actually, who bought an addition to her house in Ireland, right when she was diagnosed with leptomeningeal disease from breast cancer. And I had a very serious conversation with her. I was like, Deb, yeah, this is I'm not sure here. And she's like, well, we're gonna get this because you're gonna do intrathecal Herceptin and whole brain on me, and we're gonna get this. And 4.5 years later, she finished the addition on the house. This is a picture of her birthday party. And it's hard to overstate that, like, a person who would probably have died within 6 to 12 weeks of me meeting her is sending me a birthday picture from that far out. So does this happen to everyone? No. But if you don't try, you're never going to learn who this is possible for. And so she really helped me, because she was like, no, we're going to do this. I was like, okay, all right, we're going to do it. And I want to leave you with the idea that the future is hope. There is an explosion of central nervous system active diseases, drugs for all sorts of diseases. The top lines are, the top 2 are for non-small cell, then there's drugs for melanoma, drugs for HER2 positive breast cancer, there's IDH drugs, RET drugs, MET, NTRK, and KRAS are all disease agnostic. So if those targets are there in your disease, they can be hit now. And I think that improving survival in our patient and quality of life in our patients with central nervous system mets, it means we need to know how to test that fluid, who to test, what drugs to use. And if we use surgery, radiation, and targeted therapies carefully, we can really make a big difference for patients. So if you haven't been to a multidisciplinary clinic that has a neuro-oncologist who likes to treat brain mets, or a disease-specific oncologist, I think that's also important, then I strongly recommend it. You only get one brain, and my job is really to protect it.